Bismillahirrahmanirrahim. I am Dr. Muhammad Ramzan Ansari, Assistant Professor of Pediatric, and in today's lecture, I am going to discuss diarrhea, dehydration, and WHO protocols of rehydration. First of all, let us define diarrhea. Passage of liquid or watery stools at least 3 times in 24 hours. It is the consistency rather than the number of stools that is important. Breastfed babies often pass loose pasty stools which cannot be called diarrhea. World over, 1 billion episodes per year in children under 5 years of age, 3 to 5 episodes per year in each child under 2 years of age in developing countries or in underdeveloped countries, and 2 million children die annually, and 80% in the first 2 years of life because of diarrhea and dehydration. There are three mechanisms of diarrhea: secretory diarrhea, osmotic diarrhea, and motility diarrheas. Secretory diarrheas are caused by secretogogues like cholera toxin. Osmotic diarrhea is caused by poorly absorbed solute, magnesium phosphate, a small bowel defect like lactase deficiency on brush border, which is caused by viral infections, viral diarrheas, as well as bacterial diarrheas. And motility diarrheas are associated with increased motility, like in irritable bowel syndrome, or delayed motility, like in intestinal pseudo-obstruction. Etiology of diarrhea can be viral, can be protozoal, and can be bacterial. Rotavirus is the most common cause of diarrhea, followed by norovirus, Norwalk-like virus, enteric adenoviruses, astroviruses, enteric viruses. Uh, then protozoal, Entamoeba histolytica, Giardia lamblia, and among bacteria, E. coli, Campylobacter jejuni, Shigella, Salmonella, and Vibrio cholera remains the leading cause of bacterial diarrheas. WHO says first ask the history of diarrhea and dehydration, diarrhea, vomiting, dehydration, then look for signs of dehydration, and then feel for the signs of dehydration. Ask for frequency of stools, whether there's blood in the stools, because once there's blood in the stool, it is a dysentery. A dysentery is mostly caused by invasive organisms and usually by bacteria. So antibacterial must be added in the therapy whenever somebody has bloody diarrhea. That is dysentery. Ask about danger signs. These four are danger signs of diarrhea and dehydration. WHO danger signs of diarrhea and dehydration. And general danger signs are slightly different from this. Vomiting everything out, not able to eat or drink, meaning by the child is very lethargic, child has convulsions or loss of consciousness. After asking, look for signs of dehydration, blood in stools, and look for malnutrition. Naked eye examination of stool will be important here. Let's have a look on signs of dehydration. You can see that child is restless, irritable. He can be lethargic, can be unconscious, can have sunken eyes. You have to see whether the child is thirsty or not thirsty and the child's ability to drink. Look and feel for the sunken fontanelle. You can see in this picture clearly the child is dehydrated and has sunken fontanelle. Feel for the skin pinch. Pinching the child's abdomen to test for decreased skin turgor. Slow return of skin pinch in severe dehydration. If it takes more than 2 seconds, it is very slow uh, skin pinch going back very slowly. Based on your uh, assessment, you will classify patients on severe dehydration, some dehydration, or no dehydration. Severe dehydration meaning by that 10% or more than 10% of the body weight is lost. In some dehydration are in moderate. The other word for some dehydration is called moderate dehydration. 5 to 10% of the body weight is lost. And in no dehydration, which is called mild dehydration, in other words, less than 5% body weight is lost. So you will classify according to WHO patients having no dehydration, some dehydration, and severe dehydration. Why less than 5% body weight lost is called no dehydration? Because the child has not shown any sign of dehydration by the time he loses less than 5% body weight. When he loses more than 5%, 5 to 10%, then he shows some signs of dehydration. This is a tabular form on the assessment and then the treatment plan. Decide grade of dehydration and then decide the treatment plan which will be instituted for the treatment of this child. If child looks well, is alert, tears are present, eyes are normal, tongue is moist, his thirst is normal, and skin pinch goes back quickly, then this is no dehydration and you will use plan A. We will discuss plan A later. If child on examination is restless, his tears in his eyes are absent, eyes are sunken, his tongue is dry, and he is thirsty and drinking eagerly, and skin pinch goes back slowly, then it is some dehydration and plan B will be used. But if the child on examination is lethargic, his tears are absent, eyes are sunken and dry, tongue and mucous membrane are very dry, and he drinks poorly, and his skin pinch returns very slowly, then child has severe dehydration and plan C will be instituted for the rehydration of such a child. We will start with plan C. Plan C is used for severe rehydration. It consists of administration of IV fluids to a severely dehydrated child. Plan C states that a child with severe dehydration is to be given 100 ml per kg IV fluid. If child is less than 12 months old or less than 10 kg, then out of this 100 ml, 30 ml per kg is given in first hour and 70 ml per kg is given in 5 hours. So total rehydration time is 6 hours. In a child more than 12 months old or more than 10 kg, this 30 ml, initial 30 ml per kg will be given in 30 minutes and remaining 70 ml per kg will be given in 2.5 hours. If child after 30 minutes or after 1 hour, depending on the age of the child, after first initial 30 ml per kg still has weak radial pulse or pulse is not detectable, you need to repeat this 30 ml per kg in 1 hour for less than 12 months and more than 12 months in 30 minutes. And after completing this rehydration plan C in 3 hour or 6 hour, reevaluate after 3 to 6 hour, and if still dehydrated, plan C is repeated. This is a very important slide and has direct relationship with the type of fluid which will be used for rehydration of the child. Ringer lactate is the ideal fluid for such children because dehydrated children um, will have more salts in his body and will need a fluid which has slightly lesser ionic composition. Ringer lactate is ideal for this purpose. It contains sodium 130, potassium 4, which is more physiological, chloride 109, and lactate 28. And this lactate in Cori cycle will go to be converted into glucose, and lactate itself can be utilized in the tissue. So this ringer lactate, in addition to giving fluid, in addition to providing hydration to the body cells, and in addition to providing salts, it will provide a little bit of nutrition as well. Normal saline contains only sodium and chloride, 154 milliequivalent millimole and 154 millimole of chloride. So total 308, whereas ringer lactate has 255. When a child is dehydrated, his plasma osmolality is already little high. So we want to give a fluid which balances the plasma osmolality, and ringer lactate is best for the purpose. But in case of shock, in case of when you are unsure of the potassium status of the child and acid-base balance of the child, then normal saline is the preferred solution. Half normal saline can be given in younger babies, less than 1 year, less than 6 months, but half saline can given if given rapidly can lead to hyponatremia, can lead to cerebral edema, and is not the ideal resuscitation fluid for the purpose. And glucose solutions, because they don't contain any cations or any anions, so glucose solutions are not resuscitation fluid. These are only maintenance fluid and should be avoided in all resuscitation settings except hypoglycemia. Plan B, some dehydration. Administration of oral rehydration solution to a some dehydrated child. Plan B states that 75 ml per kg ORS is given in 4 hour. Amount of ORS to give during first 4 hour is as follow. If child is less than 5 kg, then 200 to 400 ml. If 4 to 11 months or 5 to 8 kg, 400 to 600. If 8 to 11 kg, 600 to 800. If 11 to 11 to 15.9 kg, 800 to 1200, and so on and so forth. And child is to be reassessed after 4 hours. If still moderate or some dehydrated, then again the same 75 ml per kg ORS roughly, or according to the table ORS is given according to the weight of the child. Different types of ORS are available in the market. Some are low osmolar, some are normal osmolar, but low osmolar WHO ORS is the new ORS, new standard ORS, which should be used in all settings. This is the composition of low osmolar ORS. It contains sodium chloride 2.6 gram, trisodium citrate dihydrate 2.9 gram, potassium chloride 1.5 gram, and anhydrous glucose 13.5 gram. This one packet is added into 1 liter of water, and it gives sodium 75 milliequivalent, glucose 75 milliequivalent, chloride 65 milliequivalent, potassium 20 milliequivalent, and citrate 10 milliequivalent. And this is the ideal ORS, which is seen to decrease the episodes of diarrhea and vomiting as well, and is better tolerated as compared to normal osmolality ORS. ORS can be prepared at home. To prepare ORS at home, add 4 glasses of boiled drinking water and add 3 teaspoonful of sugar, approximately 15 gram of sugar, 1 pinch of salt, and few drops of lemon juice will give you 1 liter of homemade ORS, which can be used in next 24 hours. If child has no dehydration, then plan A is instituted, which consists of administration of ORS and continued feeding at home. Plan A states give extra fluid and feeding, give 10 ml per kg ORS for each loose stool and 5 ml per kg of ORS for each vomiting, give zinc supplements for 10 to 14 days. Up to 6 months of age, 10 milligram per day, and if child is more than 6 months, then 20 milligram per day is given. Continue feeding and tell the family when to return, tell about all the danger signs, tell about the signs of dehydration, so that family can return back hospital in time. Different antimicrobial agents are recommended by WHO for cholera: trimethoprim sulfamethoxazole; for E. coli, Shigella, Campylobacter, trimethoprim sulfamethoxazole, which is Septron, nalidixic acid, and ciprofloxacin are recommended. For MABSs, metronidazole is recommended, and for giardiasis as well as metronidazole is recommended in different doses. Doses are shown in the table. Patients monitoring is done on regular basis by checking the body weight. Further body weight loss is not going on. Vital signs are monitored. Pulse rate will tell you about the state of hydration. Capillary refill time will tell you. Blood pressure will tell you about the state of hydration. Food taken, whether child is able to now take milk or other food, semi-solids or not. Fluid electrolyte balance will also be monitored. There are many complications of dehydration like hypokalemia, hyponatremia, hypernatremia, hypocalcemia, hypoglycemia, and the most common metabolic derangement is hypokalemic, hyponatremic metabolic acidosis, and further damage to the kidney can lead to uremia as well. But in uremia, there will be hyperkalemia. Further, if it leads to kidney damage, then there will be hyperkalemia. But initially, most common metabolic derangement is hypokalemic, hyponatremic metabolic acidosis. If organism is invasive, then child can have dysentery, child can have persistent diarrhea, child can have malnutrition, convulsions, vitamin A deficiency, which will further predispose the child to development of measles and malnutrition. Hemolytic uremic syndrome is a complication of diarrhea caused by Shiga toxin producing E. coli. Post-diarrheal paralytic ileus, pneumonia, septicemia, meningitis can be caused by bacillary dysenteries, bacillary diarrheas. Do not use antidiarrheal drugs and antiemetics in cases of diarrhea and vomiting because they focus attention away from rehydration. They prolong the excretion of bacteria in the stool, can be associated with side effect. They are ineffective and costly. Promotion of breastfeeding prevents diarrhea. Complementary feeding and weaning, personal and domestic hygiene, including hand washing, use of safe drinking water, vaccination, and health education of mother can prevent diarrheal illnesses. Diarrhea is a common preventable condition with high morbidity and mortality in children. It can be easily treated with simple, cheap, and effective therapy available in the form of ORS that needs to be communicated to the community through health education. ORS can be prepared at home